Very good morning, friends. Today we are going to talk about another important topic that we all know that, and that is nothing but that Empyema and Parapneumonic effusions is a very important topic. And before going to the topic, I want to say, or we want to revise about the pleural compartment. We all know the pleura is nothing but, our pleural cavities or pleural space is nothing but the cavity in between the two layers of pleura. One is a visceral pleura that is tightly adherent to lungs, and another one is a parietal pleura that is adherent to the thoracic wall. In between these two, there is a potential space, and it hardly contains any fluids. They say around 0.1 ml per kg. Why this fluid? This fluid is a very important function because it acts as a gliding. It helps the lungs move smoothly, glide smoothly during inspiration and expiration. And what they say, the pleural cavity is the one that is a negative pressure, anywhere between -5 to -10. That is also very, very important because this minus pressure is very important in the initiation of inspiration. Actually, how the fluid form and how it get drained, I think it is beyond this topic. Since the oncotic pressure remains the same, the hydrostatic pressure in the systemic circulation that decides the pleural movement from the parietal pleura, and finally it is drained by the lymphatics. Sometimes this nice pleura, actually it is a very sterile compartment. It get either infected or inflamed or traumatized. That may go for a problem. If anybody asks what is a problem or what are the problems that go with the pleura, is number one is the pleurisy. Pleurisy means nothing but inflammation of the pleura. Sometimes we can call it as a pleurite. Naturally, it may be due to any viral. Usually, it's a viral infection. What they say, it could be due to the influenza, Coxsackie, and even adenovirus, all implicated. And it also might be due to bacterial infection. Such infection, because of the inflammation of the parietal pleura, and parietal pleura is sensitive. There is a pain receptors are there, so it causes a sharp pain. So if anybody says I am having a pain in the chest like that, and if you are ruling out the other causes, and one of the differential diagnosis is the pleurisy. These children may present with a cough, chest pain, and it runs for about a week. Sometimes there is a collection may happen in the pleural cavity. It may be a transudate or exudate. How to differentiate between these two? Probably 1 or 2 slides I may tell you. We all those days read about the Lights criteria. That may be very useful to differentiate between the transudate and exudate, because transudate is the one, it is a natural process because of the reduction in the oncotic pressure. Fluid accumulation occurs, third space, it is act as a third space. Whereas exudate is the one that you definitely have to manage and you have to remove it. Parapneumonic effusion is nothing but, as the name implies, it is a complication of pneumonia. Pneumonia itself is a killer disease, and because any child who has been diagnosed as pneumonia should be treated very fast with empirical antibiotics, because there is no time, and we are not going to discuss much about the pneumonia. But one of the complications of pneumonia, see, it may go for a lung abscess, or sometimes it may do to effusion, or it may do to empyema. I think we are going to discuss about the parapneumonic effusion and the types of parapneumonic. What they say, parapneumonic effusion is nothing but a complication of pneumonia. May be simple or uncomplicated, or it may be complicated. Why this delineation is important, that we are going to discuss. If you are able to demonstrate any frank pus in the pleural compartment, it is called as pleural empyema. Sometimes it is called empyema thoracis. These are all things. With this background, I want to revise your knowledge regarding the pneumonia and empyema. Pneumonia is a alveolar process. We all know some of the organisms enter evading the defense mechanisms and enter into the alveoli, and it immediately go for 3 stages of congestion, 4 stages: congestion, red hepatization, grey hepatization, resolution. And most of the pneumonias, if you give a correct treatment depending upon the age or the setting in which occurred, or nutritional status or immunological status, the pneumonia usually cleared within 1 to 2 weeks and all. But empyema is not acute process, it's a chronic process. Here it is happening in the pleura. I already said pleural compartment is a very sterile one. Somehow the organism organism get entered into this pleural compartment, and that go for typically 3 stages. It's a prolonged one when compared to pneumonia. First one is exudative. There is a lot of inflammatory exudate happening with a minimal fibrin. What they say here, your antibiotic therapy may also be very useful to clear the stage 1 process. But most of the times we confront a child presenting with a fibropneumonic stage. It's a the duration you look at that, somewhere between 4 to 13 days. And managing this situation is very, very difficult. That's what we are going to discuss. And there is an increasing formation of fibrin clots. We go for septation, localization, and there they say the role of chest tube and fibrinolytics and all we are going to discuss. But once the child go for severe after 14 days, the fibroblasts lay down the collagen and form a thick fibrous peel both on the visceral and pleural pleura, and in fact they may adhere together also. That will limit the lung expansion, and it is a very it's procedure that needs definitely a surgery. I shown the 4 X-rays. We all know pneumonia as a killer disease. I said most of the times it gets settled with antibiotics, but rarely, what they say, 30% of the pneumonia may go for complications, parapneumonic effusions. Again, that's what look at that. This is a simple, probably it's a I think these are all not the same patient, don't confuse. Just I have shown the X-ray. Pneumonia going for complications, parapneumonic complications, and sometimes it may be a simple parapneumonic effusion or complicated parapneumonic effusion. I think this classification is very important. We are going to discuss, and it may also end up in empyema. Okay, and that is what we are going to discuss, how to approach this condition, how we have to differentiate simple versus complicated parapneumonic effusion, empyema and all. When you suspect parapneumonic effusion, you are treating a pneumonia, most of the child it will respond, but some of the child may admitted with a severe pneumonia, and there may be a rapid progression in spite of antibiotics. Child may not improve. Child may continue to have high fever, toxic, dyspnea may be increasing, and there may be a fall in the saturation. And clinically, the child may start developing, instead of a dull note, it may develop a stony dull note, becoming sick, toxic. Air entry will be completely absent. And if you repeat the X-rays, the radiological worsening might be there. And sometimes, if all these things happen in a child who are already developing a skin boils or post-missile state, we can even predict the organism. It could be a staphylococcus. But usually, that PPE, the complication is due to streptococcus pneumonia that we are going to discuss. Then what to do? If places ultrasound is available, I think the ultrasound is a very useful investigation. When compared to X-ray, ultrasound is a better one, but most of the times we have to go for both. in addition to full blood count and acute phase reaction. See, if you compare these counts, CBC may be neutrophil may be very much increase, CRP may be increase. I think and best way to document the fluid is the ultrasound. Ultrasound shows the presence of not only the presence of fluid but also the quantify the fluid. How much amount of fluid is there? Is it free flowing in nature, or is there any substations, or is there any loculation? And it also tell us about the best site for thoracentesis. Those days we have a clinically we just percuss and we will find out where is a maximum dullness. There we will introduce thorax needle, and today ultrasound helps a lot. When compared to X-ray, ultrasound is superior because it detects as small as 5 ml. That is the advantage of the ultrasound. What is then once you document the fluid, then you have to go for thoracentesis. Sometimes it is also called pleural tap. It is nothing but percutaneous needle aspiration of the pleural cavity, and you have to remove minimum fluid. Those days sometimes we have been talking about the therapeutic thoracentesis and all. Don't do that. And once you demonstrate fluid, take a small amount of fluid and probably 10 to 15 ml. It has to be subjected for all the investigations that we are going to, including biochemical, microbiological investigation. But while you do needle aspiration, be careful, because you always put a needle through the upper border of the rib, because in the lower border of the rib, the neurovascular bundle travels, so you may injure. That's the reason why we always advise, even in the ICD tube or in the introduction of tapping, we always introduce the needle through the upper border of the rib. Before going to the analysis of the fluid, pleural fluid, we should know what is the normalcy, what is the normal constitution. See, something like that blood count. See, blood count, CBC, how you interpret, we should know normal neutrophil is around anywhere between 50 to 60%. Lymphocytes is 30%, like that. Here also, we should know about most important thing is the color. Color is clear. And pH is anywhere around 7.6 and protein is 1.5. This knowledge is very, very important. Then only we can differentiate whether it is a transudate or exudate and all. And other important parameters are glucose, that is almost 2/3 of the blood glucose. LDH is around, LDH and glucose, they reflect the activity of the bacteria as well as leukocytosis, leukocytes. If the bacteria and the leukocytes more and more, glucose will fall down and also LDH will start increasing because hydrogen is produced in the cavity. That's the reason why it may be acidic, and glucose may fall down, LDH may increase, and pH may also decrease. I think this all I just to show this lights criteria because sometimes it's a very exam question for you. In the light criteria, if you do a pleural tap and it is a very clear fluid and everything, pH, protein, glucose, LDH are all on the transudate side, then we can say it is not due to infection. It may be due to either increase of hydrostatic pressure or diminution of oncotic pressure. And the conditions may be due to the associated nephrotic syndrome, or it may be cirrhosis, or maybe congestive cardiac failure and all. Sometimes the pleural compartment may be due to infected, inflamed and infiltrated. At that time, the pH, everything may change. The fluid itself become exudate, it become turbid, or even a frank or serous purulent fluid may be you come across. There definitely the pH, as I said, will start falling below 7.2, protein starts rising above 3, and the glucose also starts falling, and LDH starts increasing. I think this knowledge is very important. I think same knowledge we can use to differentiate parapneumonic effusions. See, I already said parapneumonic effusions may be uncomplicated or complicated. Sometimes we can call it as a simple and complex. And of the three parameters, pH, protein and LDH and glucose, the most important parameter is the pH. The usual question is how to measure the pH. I think don't use the litmus paper and all. Go for very nice. You all your institution may be equipped with the ABG analysis. So you take the fluid, submit the same thing like a ABG analysis. Then we can instantaneously get the report that may be a very correct one. But don't rely upon the paper and all. Litmus something like a paper derived pH and all. When the pH is more than 7.3, I think you are very sure it may be a simple one, and anything less than 7.2, it is a complicated one. Naturally, the other parameters like a protein and glucose, LDH, all these things, as I already said, you have to compare, and that help you a lot. But once you strike, if it is going to see a pus, frank pus, I think these investigations may not be required, not necessary to do it. Some people may be confused, even with the pus they will do it, not necessary. Only if you get a turbid fluid, you have to differentiate whether it's a simple parapneumonic or complicated parapneumonic. There you have to go for this sort of the differentiation. Once you get a frank pus, you can straight away go for you make a diagnosis of empyema and you go for the further treatment. What further treatment? Actually, if the child is fell into the category of uncomplicated or simple parapneumonic effusion, I think the treatment may be the child may not require at that point ICD incision and all. And many times you can pull on, continue or appropriate antibiotics may with the monitoring with the other things, the child may become all right. So you should have a supportive management along with antibiotics. But once the child fit into the category of complicated parapneumonic effusion, and like this, you have to same measures like empyema. How your empyema you are treating, that we are going to discuss. Same thing we have to do that. Sometimes these days of ultrasound, a good sonologist may say by looking at the echogenicity, whether the child, he also add his own contribution to decide between the simple parapneumonic versus the complicated one and all. Now we straight away go for management of empyema. So empyema, that includes complicated parapneumonic effusion. Both are same. You can manage these two conditions together because they want different type of management. Among the medical, the most important thing is chest tube drainage. You have to remove the fluid. That is very, very important. See, wherever the dictum is, wherever there is a pus or wherever there is a pus, purulent fluid, we have to remove. So the most important thing is that one, as well as the good antibiotics, appropriate antibiotics. And fibrinolytics, I think these days there is a lot of controversies about that, and some discussions are going on. I'll just touch upon that. And when surgical techniques like VATS or debridement with VATS or thoracoscopic debridement or decortication, we are going to discuss. I think in the management, the most important thing is the monitoring. Monitoring is very, very important, and you have to always look at the child nutritional status, fluids, as well as the oxygen. All these things are all understood. Before going to the antibiotics, you should know, some people may think that Staphylococcus empyema, it's not like that. Still, what they say, the most common organism when the community acquired pneumonia, go for complication, you have to think of Streptococcus pneumonia. I think Streptococcus pneumonia, you have to read everything about the Streptococcus pneumonia. And there are situations, Staphylococcus, Haemophilus influenza, and in the developing countries, you have to always think in the back of mind, tuberculosis. And by and large, when a CAP, community acquired pneumonia, go for a complication, you should always think Streptococcus pneumonia and as the causative organism. Sometimes you can get the culture, you are lucky, but unfortunately the culture hardly contributes anywhere between 5 to 10%. So this knowledge is very important. So coming to the antibiotics, what antibiotics? And without treating the infection, see, pneumonia itself warrants a good antibiotics. When it is go for a complication, you should be all the more caution. So what they say, ideally, since we are telling that the Streptococcus pneumonia is the most common organism, you better go for combination of ceftriaxone with cloxacillin. Any beta-lactam antibiotics still works better, and that knowledge is very important. This you can continue for at least 5 to 7 days, and if there is no response, you have to think of other organism. Sometimes staph could be there, or sometimes good gram-negative organism might be there, and including anaerobic thing you have to think of. So, secondly, in drug, what they say, if there is no adequate response and a child cannot respond with the ceftriaxone and cloxacillin, go for Vanco, adding Vanco, or some people prefer to go for linezolid. I think among the two, many people consider addition of Vanco is very, very important. When there is your CT, your contrast CT shows that there is a possibility of underlying necrosis, parenchymal necrosis, I think clindamycin is a better drug. And how long the child should be treated with intravenous antibiotics? At least till afebrile. Probably it may take another 10 to 12 days or something like that. Once it becomes afebrile, then you can put the child on oral antibiotics to complete the therapy at least for 3 to 4 weeks. Chest tube incision, I think this itself is a separate topic I used to discuss. I have just depicted the same triangle. Actually, the triangle is anteriorly by the pectoralis major, laterally by the latissimus dorsi, and inferiorly by the fifth intercostal space. And what they say, you can choose either a fifth or sixth intercostal space in the mid-axillary line. And this is the ideal site for your chest tube incision. Sometimes you can call it as a tube thoracostomy, because we have to naturally remove the that pus or purulent fluid. And I already said during the incision, I think it also slightly varies. Some people follow Seldineger technique, and you have to avoid the injury to the neurovascular bundle and all. Coming to the ICD care, I think it's a very important one. Many people may put the ICD, they don't know how to care the ICD tube. Actually, after putting the tube, if the tube is there in the pleural cavity, then the air column in the tube is nicely sewn. Actually, you have to put the tube that has to be connected with the water seal drainage. Once you do that, and because of the negative pressure in the pleural compartment, there is air column, as well as the air column in the water seal is nicely go up and down. And please avoid undue very long tube is not advised, because these undue undulations, or you have to avoid unnecessary undulations. You use a correct size for a correct child. That is very important. Second thing is, sometimes before we also believe a big tube means it will drain. It's not so. And the study shows that even a small bore tube, pigtail catheter of 14 French, is going to do it. But again, while draining, you have to be very careful, and don't remove all the fluid, because sometimes the empyema may be very, very gushing out. You remove at least 10 ml per kg, and you try to clamp also. And some centers, in European centers, if get blocked, they can, or sometimes to increase the patency or to increase the drainage, they use saline flush. These are all things. But one thing I always say, when the empyema tube is not working, you please call the surgeons, you change the site, because the tip is not in the pleural cavity. That is what that. If it is there in the pleural cavity, these are all happening when there is a loculation. When there is a loculation or septation, I think empyema will not work. Then you have to be very careful. You have to adjust the tube, and sometimes how long to keep it. I think I want to finish this one before going to the fibrinolytics. Actually, don't wait, because every day after 4th or 5th day or 6th day, many times that drain may come slowly. And if the drain, empyema drain or the fluid drain comes down 30 ml, I think no need to wait further. You can remove the ICD tube. Only thing is, you see that if there is a constant bubbling, then I am bubbling in the water seal, that denotes broncho, what is that? Broncho pleural fistula. Actually, sometimes these BF fistulas are very, very bronchopulmonary fistula, or such a thing might be there, and you have to be very careful, and you have to monitor the child closely with the ultrasound. And once the child's become good, fever is reduced, child developing good appetite, able to ambulate, then you can remove the tube. Not necessarily wait up to complete drainage of the tube. Even it is come to 30 ml, you can take the tube out, but you have to monitor for another 2 to 3 days. What is the role of fibrinolytics? There are 3 fibrinolytics are used: attapase, streptokinase and urokinase. Actually, the purpose is all these things, because of the thrombolytic action, they release the septations and localization. Sometimes they may also do enzymes. Some studies they find along with that they also use RNAs like enzymes and all. Actually, what they say, if at all they work in the early course of empyema, and they effectively dissolve the fibrins, thereby increases the pleural drainage. But remember, any child with a bleeding diathesis, it should not be used and all. And again, there are a lot of papers telling about the advantages, and sometimes some paper even say, with even some reviews say that they not have a significant advantage also. Among the 3, urokinase and streptokinase have a neck-to-neck comparison, and the dose also differs. In less than 1 year, remains the same, 10,000 units, both streptokinase and urokinase. Actually, urokinase is the one that derived from the urine. It is an enzyme, but it seems to be very expensive. And both the thing, you have to keep it, and you have to give 6 doses for 3 days, in 2 doses per day for 3 days. And after calculating the dose, you have to put into the ICD tube, and you have to close the the dwell time should be at least 4 hours. Then you have to remove. So what they say is 6 doses for both urokinase and streptokinase. I think while you decided to go for this, you also consider the cost. Some centers, they believe more of a VATS rather than fibrinolytics. If the child is developing a lot of septations and localization, they never want to miss them, and if the competent surgeon is there, they straight away go for VATS. Coming to the surgical modalities, when to go for surgical modalities, you are treating empyema, and you are already given enough ICD, and ICD radius is already more than 1 week, and sepsis continues, the lung absorption is going to be inadequate, then you have to go for surgery. Among the surgical modalities, most important thing is the VATS. Today, VATS is a very, very useful one to remove not only the fibrin, septations, localization, but also they even they remove the peel also. Some centers will do, because thoracotomy means we need to go for a big. Actually, there is a lot of, if you happen to see how the pleura, there is both the pleural compartment, both the visceral and pleura stick something like a bread and butter, and it's very difficult to, so you have to go for a VATS surgery. And if it is still VATS is not going to help, you can straight away go for decortication. Sometimes you have to go for that also. What is VATS? VATS is a very minimally surgical technique. Keyholes, they simply put 3 holes, and one through the one they have a video, and the other one and the other 2 they operate. Actually, what they say, it is very comparable to even mini thoracotomy and all. In trained hands, they do wonders with the VATS. They can even remove the thick peel, but it may not be available in all the centers. That's the reason why we have to go for decortication and all. And there are 2 types of VATS. They say that the primary VATS and actually primary VATS is nothing but when the child within about 7 days, no response, started developing a lot of septation, localization. I think many centers, why to wait putting a ICD tube for a long time? Go for VATS. That's what the idea, and that also works very well. It all depends upon the availability, competency of the surgeon, and what is how they treat their protocol. All these things are all very important one. And I already told about the secondary VATS. If the normal ICD fails, we have to go for before decortication, secondary VATS can be done. So coming to the last slide, actually parapneumonic effusion and or the simple and complicated one, and a frank empyema. These are all considered to be pneumonia complications. So we all know pneumonia itself is a killer disease. So it's something more than that. So it's very careful, because the mortality wise, if you compare, it is little more than pneumonia. At least 5% they say, even in a good centers. So once the child started developing complications like parapneumonic effusion or empyema, you should be every day you have to go and see the patient. Your clinical examination is very, very important. Once you put the tube, you have to see personally whether the tube is functioning. If the tube is not functioning, I think empyema may not go, and it will go for more complications. Sometimes it may go for empyema necessitans. See, the pus want to get away either through the parenchyma or the chest wall. Through the chest wall, it is called empyema necessitans. Through the it is a bronchopleural fistula and all. I already talked about how to manage a complicated parapneumonic effusion, and I also told about a complicated parapneumonic empyema. Both are more or less same, and most important secret is the ICD tube. Okay, that is very, very important. And once the child started developing a very thick fibrous peel that will prevent the lung to expand, then there is no choice. We have to go for decortication, and I already talked about that. I think we have discussed about everything about the empyema and parapneumonic effusion, particularly simple and complicated parapneumonic effusion. Thank you very much for patient listening.